So MDR-TB is the problem. So it's a man-made problem, can occur both in pulmonary TB and EPTB settings. It's very important because it's costly, deadly, and debilitating, and is the biggest threat to the global control strategies of TB. So according to WHO data, there have been about 1.3 million TB deaths, including 167,000 deaths among due to TB and people living in HIV. And in 2022, it has been estimated that there have been about 10.6 million people who fell ill with TB. The Sri Lankan situation is a little bit better, and we do have a low MDR prevalence. That is because of the dots. We say that we are doing dots, but and TB drugs issuing only to the state sector is very important. It's not been freely handed over to the private pharmacies or other hospitals even. No TB drugs in private pharmacies, well-established network of health system and organized PMDT active. PMDT is Programmatic Management of Drug-Resistant Tuberculosis. So with comparison to the global scenario, MDR-TB in the globally new cases, among new cases, it's about 3.5%. In Sri Lanka, about 0.5%. Among retreatment cases, it's about 18% in globally, but we do have around 4%. This is the MDR-TB facility at NHRD Valisara. You can see the difference of the turbines and the glass-roofed, glass-topped roof, and to get the things out and get destroyed by the UV lights. So when you are faced with a patient, these are the steps you follow. When you are faced with a patient with MDR-TB, it is done mainly in the NTRL, National TB Reference Laboratory or regional laboratory. And we inform the district TB control officer, the coordinator, track the patient, admit to MDR ward of the NHRD, confirm the diagnosis needed to confirm. We do the pre-treatment evaluations, counselings, written consents, starting the treatments. We contact tracing and screening at the DCC level or district chest clinic level. Monitoring for the adverse drug reactions very important in the MDR-TB, and they are kept in the ward until they become sputum positive, sputum negative on at least on 2 occasions, and then they are discharged to for continuation of SLDs are the second line drugs, and then you need to have a post-treatment follow-up for at least 2 years. So when you look at the numbers of MDR cases, we've been having around 15 to 20 patients per year, and it's been dropped in 2020 to 16, and again because of the COVID and the financial crisis, 2023 it stepped up with the clearance of the backlog as well. So when you talk about drug resistance, there are different types of drug resistance. Could be acquired resistance, that is the presence of resistance in a patient who has been previously treated at least for 1 month with anti-TB drugs. And maybe primary resistance, which is the presence of resistance in a newly diagnosed patient who has never been exposed to anti-TB drugs or has received anti-TB drugs for less than 1 month. Or wild-type resistance in a colony of MTB. There could be a few organisms which are resistant to a given anti-TB drug, not because of the previous exposure to the drug, but due to the spontaneous genetic mutations. So resistance could be monoresistant, polyresistant, multi-drug resistant, or extensively drug resistance. So depending on the efficacy of the main anti-TB drugs, we talk in terms of FLDs and SLDs. FLDs are the first line drugs. The SLDs are the second line drugs. There are different purposes are served by these anti-TB drugs at different levels of the multiplication of the organisms. When you talk about monodrug resistance against one first line drug, H, that H is INH, rifampicin, ethambutol or pyrazinamide, the treatment is uncomplicated, duration may be prolonged, the total duration. When you talk about polydrug resistance, that is resistance again more than one first FLDs, but sensitive to H and or RH. The treatment again usually uncomplicated, duration is prolonged. When you talk about multi-drug resistance, there is resistance again at least both R and H, that is rifampicin and INH, without resistance to any other anti-TB drugs of the FLDs. Treatment is complicated, duration is prolonged, and outcome depends on the level of drug resistance. So I go to extensive drug resistance, that is MDR plus resistance to any of the group A drugs, that is any of the fluoroquinolones, and at least any additional group A drug, that is bedaquiline and linezolid. Treatment again complicated, duration is very prolonged, outcomes depending on the again drug resistance. So when I go back to pre-XDR, it is MDR plus resistant to any of the fluoroquinolones, that is levo and moxifloxacin. So XDR means MDR, fluoroquinolone, and the group A drugs, bedaquiline and linezolid. So there are other types of resistance of rifampicin only resistance and INH resistance as well, right? Okay. So earlier, they were in the pre-antibiotic era. Are we returning back to the pre-antibiotic era where we do not have any drug to treat? Earlier, the colonies were drug susceptible. Then we developed the MDR-TB in 1990s. Then 2006, for the first time, they introduced this XDR, and there could be total drug resistant cases as well. We did not have any XDR patients in our country. We had couple of pre-XDRs, but the first time we detected an XDR just 2 weeks ago, and he died. So it's a grave concern, more difficult to treat, require treatment with reserve drugs or SLDs, and have to be given for a longer duration. And they are more toxic, more expensive. There are special concerns about the weakened immune system. And with all this, as a result of all this, the treatment outcome may be poor, mortality may be high. The causes of drug resistance, there may be service factors and patient factors. I said that initially, and MDR-TB is a man-made disease. So there would be service factors like introduction of single agents, that you should not add single agents to a failing regimen, incorrect drug selections, incorrect drug dosing and durations, drug quality and bioavailability, and poor case managements are the results resulting in this. Patient factors may be due to compliance, social issues, HIV co-infection, substance abuse, exposure to multiple patients as they are in a healthcare worker, treatments done in outside of the national TB program. For example, our neighboring country, whereas we are having about 25 patients we detecting over the last 2 decades, but our neighboring India is having a caseload of about 140,000 MDR cases. That is, they are using their own regimens. In many places, they practice the drugs are available in the outside pharmacies and so on. So when you talk about current management of rifampicin resistance or MDR-TB patients, the basic components of the management include finding drug-resistant TB patients among the risk groups, correctly identifying the organisms as drug-resistant TB, providing appropriate management regimens, management of adversity is very important, and preventing of the transmission by proper infectious control measures. So risk groups are there. There could be sputum positive unique category of patients, remaining positive at the end of second month. We expect them to convert to negative. Sputum positive retreatment cases, remaining positive at the 3rd month. All previously treated patients, substance dependent for institutional patients like healthcare workers, and kind of could be the risk groups. So whenever you are faced with the risk group, you need to think the possibility of MDR-TB. Now, it has been instructed by the National TB program to send, whether it is sputum positive or negative, send all TB patients sputum samples for AFB cultures and gene expert technique. But even the WHO mission, when they came last time, about 3-4 months ago, they highlighted that it is not being done even in the Colombo district or the Gampa district. We do it university for all patients. So it's very important to carry out this pre-treatment testing. So collectively identifying the drug-resistant organism, very important. There could be phenotypic diagnosis and genotypic. Phenotypic is you are looking at it to the naked eye, and there are first-line DSTs and second-line DSTs or drug susceptibility testing. May be done on automated liquid culture or even on solid culture, or molecular improbasis could be performed. So as I said, phenotypic and genotypic testings are there. The culture-based methods are important for aminoglycosides, polypeptides, and in the liquid culture methods. And also they are used for MTB diagnosis and monitoring. And DSTs for fluoroquinolones, levofloxacin and moxifloxacin is very important because the one of the most important MDR managements are decided on whether they are fluoroquinolone resistant or not. So on solid media, the FLDs, streptomycin, HRE, the results are there within 82 weeks if it is a positive culture. If it is a negative culture, it will be more than 8 weeks. On the liquid media, for positive cultures, it will be about 21 days, but they keep it for 42 days before issuing. In addition to this, ZDs, pyrazinamide also could be given a positive result in the liquid media. On the genotypic testing, those are the molecular testings. We have considerable advantages because of the high speed standardization of the techniques and the high output and reduced requirement for biosafety, unlike in the culture methods. There are 3 types of testings: the nucleic acid amplification or NOTS, and the line probasis, and also the most advanced one is the next generation sequencing or NGS or whole genome sequencing. We do not do it here. CB0 is the cartridge-based, CBCAN cartridge-based nucleic acid application test. There are 3 types of them. Earlier one was the gene expert, the expert MTB-RIF. Then came the expert MTB-RIF alpha, and we do have the MDR experts or MTB XDR panels. If you talk about the expert, the basic one, we detect the 2 informations we provide is the MTB complex is positive or not, or whether there is rifampicin resistance, that is the RPOB gene mutation, directly from the sputum sample. It is provided within 2 hours. It has a similar sensitivity, specificity, and accuracy for the Kayas culture on liquid media. Can be used for smear positive or negative specimen. Even for the negative specimens also you can have it. Ultra, the same panels, same genetic platform is used, but improved sensitivity and detection of the same information, but they can detect very small numbers on non-viable or non-replicating bacilli even. But you have a problem here. You may get a report called a trace reports. When it is on ultra, when you get a trace report, we do not consider it always just going to be like MDR TB. It may not be MDR on a trace report. We do a repeat test and see, because it may be just a wild type persistent that has been picked up by the high sensitive testing. Expert MDR panel detects fluoroquinone, ethanamide, amikacin, and INH. Results are given within 90 minutes. If you consider the line probasis, they are done on, they cannot be done on smear negative patients. So in difference to the previous gene experts, currently done on culture isolates, they can detect resistance to HR, fluoroquinolone, and the second line injectables. It's a strip-based rapid molecular technique and provides results within about 2 to 3 days. There are 2 types of LPS as well, the primary LPS or the FL. First line LPS and the second line LPS, both are done in Valisara. The first kind of things will give an RH rifampicin H12 sensitive patterns, risk or not. The second line will give fluoroquinolone aminoglycoside patterns as well. So interpretation of mutations detected at LPA for INH resistance, you have this CAT-G mutation and or INH-A promoter and CAT-G mutation. And moxifloxacin, we give the genes GAIR-A and plus GAIR-B. And also pyrazinamide also has a different molecular detection. This is the next gene sequencing where you can rapidly, accurately detect all clinically relevant mutants. This is another one of a gene expert like one, TrueNet. It's also available in this country. It's a chip-based real-time PCR, micro PCR one. It again detects the same as the gene expert, MTB resistance. Specificity is about 98%, less sensitive than gene expert. So when you are faced with the patient, you have to provide the treatment regimen and doses. So patients may be registered and started on SLDs, the second line drugs, on the basis of the significance of as a risk for drug resistance before the laboratory confirmation. But all attempts should be made to confirm the microbiological status of the resistance. The basic principles are you should not add single drugs for a failing regimen. Dots should be practiced in all MDR cases. You need to arrange the second line DSTs as early as possible. You need to change the therapy accordingly. You may select drugs according to likely source of the case of the DST results as well. Well, the following up of the patients will be clinical and bacteriological and radiological, clinical monitoring during the ward treatment and all the outpatient visits. And you need to counsel the patients and the child or caregiver if in the case of pediatric patients. So when you formulate the regimens, there could be standardized treatment regimens or STRs, or there could be individualized treatment regimens because of their exposures, their sensitivity patterns and all. The STRs suspected should be confirmed whenever possible, confirm the diagnosis and same. So we will continue the treatment and individual treatments, same as I said. So these are the armament. This is the armament of our anti-TB treatments. You have the basic first line, then you have the second line, the injectables, and which are going out of phase now. The quinolones, ofloxacin also now going off. We have the levo and the moxi, and we have the second line, the ethanamide or prothonamide, and cycloserine, PS, and the newer drugs were the delaminide, linezolid, bedaquiline, and clavonic, and the clofazimine, clarithromycin, and tazobactam. So there have been different groupings from 2011, 2016, 2018. Different groupings have been introduced by the WHO. The latest one is the groups on group A, B, and C. The group A will have the ones, the quinolones, then the bedaquiline and linezolid. The group B, we have the clofazimine, cycloserine, and the group C will have the nivo1, the delaminate, and ethambutol, pyrazinamide, and the rest of these things, including the carbapenems. So the current drug treatment strategies we employ at the moment, there are 4 types we use depending on the patients. We have the standardized shorter all oral treatment regimen or SSTR. This is for 9 to 12 months. Earlier treatments of minimum earlier, before the introduction of these things, few years ago, it was 18 months plus or 20, 24 months. So it's 9 to 12 months. Preferred treatment regimen is that. And we also have a longer treatment regimen of 18 months if you cannot get them into this group. And we have something called a BPAL regimen where you have, then these are the newest ones, the bedaquiline, protaminate, and linezolid. And there's another one called BPAL-M where it has been added with moxifloxacin, which is 6 to 9 months duration. And if really sensitive, you may use the 6 months treatment like in a normal anti-TB treatment, first line drug regimen, it can use. When I did the lecture 4 years ago, the treatment, the cost was about close to 1,500 USDs per patient. Now, with the addition of the shorter regimens, it has been dropped down to about 400 USDs now. So it's in advancement. So the standard regimens, you have this 7 drugs in the OSST shorter regimen. And these are the treatment durations. So I will quickly finish this off. And there are various categories we consider in these patients, and whether they should not, for the shorter regimens, they should not have extensive TB disease or severe form of EPTB like the CNS TB, osteoarticular TB, and also disseminated TB. And the longer regimen, you have this, the groups I have discussed earlier, the group A, B, and C. They strongly recommend all 3 of the groups should be included, and at least one from this also be included in the regimen to compose 4 drugs. If you cannot have all these drugs, if you can have only 2 drugs, then we will add 2 from here and 2 from here. If you are getting only 1 from here and 1 from here, you will include more and more drugs from the group C as well. And also, depending on the sensitivity patterns, you will go for the longer regimens or different in IT individual treatment regimens as well. So I would not go into the details of these things. So the OLTR or the longer regimen we used for the severe form of EPTB and extensive lung disease as well. If you have a suspicion of pre-XDR or XDR, because obviously it's for longer treatment duration. And BPALM recommendations, earlier it has been given for fluoroquinolone resistance, and they gave a conditional recommendation for the use for the other patients who are not having fluoroquinolone resistance. Now they have suggested, it has not come into the guidelines. We practice this also, whether they qualify into these things, whether they could be started on this is only 4 drugs, bedaquiline, protamide, and linezolid and moxifloxacin, but so that if there is fluoroquine resistance, it's encouraged to use as well. And so I will not go into these details of these things. And again, this is a BPAL regimen. So monitoring of the adverse effects are very important on these patients, because if you are using the BPAL regimen, many of these patients are having, for example, if you are using linezolid, you have a severe problem of anemia, myelosuppression, and different kinds of severe anemia, white cell count, and the platelet dropping, and also severe neuropathy are the problems. Again, QT prolongation may be there with bedaquiline, clofazimine, and moxifloxacin, peripheral neuropathies, and all these things are there. So you need to bear this in mind when you're starting your treatment regimens. So following up the patients, very importantly, we send cultures of these patients every month, direct smears and cultures every month from the 2nd month. And sputum conversion is considered as when the patient is sputum cultures negative on 2 occasions, when the samples are taken 30 days apart. The date of conversion is considered as the first date of the 2 negative samples. So I think I will not go into the details of these things because of the obvious time limitations. So very importantly, you need to evaluate the patient. Basic evaluation is very important, because some of the patients you cannot use the drugs, and you need to have a detailed clinical evaluation, including pregnancy and breastfeeding. The drugs like ethanamide cannot be given during pregnancy because of the teratogenicities. So we need to go for these things as well. And we will be doing the laboratory initial pre-treatment, and at the end of every month we'll be doing the evaluations, laboratory, microbiologically, as well hematological and biochemistry, and test exercise at 6 months. All these tests have been done. So we are faced with challenges when you're managing MDR-PB, because the problems of confirmation and where to keep these patients. We do have only a single ward for the whole country. the social issues of long stay, the economic issues, adverse drug reactions, suspected XDR and pre-XDR cases. All these are challenging as when you are managing MDR TB patients. Thank you.